Hello, I am Eli Adashi, Professor of Medical Science at Brown University and host of Medscape One-on-One. Joining me today is Dr. Douglas Bettcher, Director of the Tobacco-Free Initiative of the World Health Organization. Geneva-based but well-traveled, Dr. Bettcher is the global face of WHO's program on tobacco control. Welcome.
Thank you.
Great to have you. You, better than most, recognize that tobacco claims 6 million lives a year, or one person every 6 seconds, thereby accounting for 1 in 10 adult deaths. Where does the Tobacco-Free Initiative come in vis-a-vis these rather dramatic figures?
The Tobacco-Free Initiative was actually, and it's gone through an interesting metamorphosis since its first emergence, development in the summer of 1998. This was the same time that former Prime Minister Dr. Gro Harlem Brundtland took over as the elected Director General of WHO in July of 1998. And there was a feeling that there was a discrepancy between what WHO was saying about the tobacco epidemic as one of the largest preventable causes of death in the world, but yet we had a very small budget. I think we had 2 people working at headquarters and very, very few people out in the field working to support member states in their fight against tobacco. And also on the books, there was a plan to negotiate WHO's first treaty, the WHO Framework Convention on Tobacco Control. And Dr. Brundtland took this to heart as part of her restructuring of the organization, reform of the organization. She felt that our budgeting and our priorities should match the big killers, those determinants of major disability and deaths around the world. So she established the Tobacco-Free Initiative as a major high-level cabinet project. And the first part of that work was to really support the 190 odd member states of WHO to negotiate their first treaty.
So the Tobacco-Free Initiative preceded the convention.
Exactly. It was kind of the seedbed, the secretariat, the support for our member states to do this unprecedented negotiation. For listeners, I mean, it is a treaty like the Framework Convention on Climate Change and the Kyoto Protocol on climate warming, which we hear about in the news frequently. So the global community, all the member states of WHO, decided to move forward with this daunting task of doing something which was in our Constitution but had never happened, to negotiate WHO's first ever treaty. And so the Tobacco-Free Initiative's life course, let's say, has evolved along with the growing up of the Framework Convention now to a full-fledged adult treaty with 174 parties, with its own secretariat. And we have, I would say, evolved with that work. And the Tobacco-Free Initiative now really is a network, a global network. We have people in over 20 countries working to assist governments with their laws, advocacy, communication programs, working with partners, helping them to retool and strengthen their surveillance and data monitoring systems to measure the progress of the tobacco epidemic and achievements. Our Director General often says, Dr. Chan is the Director General of WHO, who says, what gets measured gets done, and that's also one of our big tasks. And we've had the distinct pleasure and honor to work over the last 4 years with partners that have evolved out of Mayor Bloomberg from New York here has made one of the largest donations in the history to NCDs, particularly on tobacco control. Given the successes of tobacco control in the city, he felt that this was a scalable endeavor for the world, and has donated $375 million to global efforts on tobacco control. And Bill Gates and the Gates Foundation also came on board in 2008 and has also brought $125 million into support for scaling up the implementation of the Framework Convention. And those funds are being used to, at country level, to support countries' work to counteract the devious and unacceptable practices of the tobacco companies, which are constantly and ruthlessly looking to accrue profits and at the expense of millions of deaths a year. And we are part of a partnership network, 5 partners with the Bloomberg Initiative, and 3 or 4 partners in Africa now with the Gates work that we're doing. So, and the message is that real differences are being made, actually. I mean, we just released our 3rd global report on the tobacco epidemic in early July of this year in Uruguay. And we showed that over 1 billion people now have been newly covered by an effective tobacco control measure since 2 years, since 2008.
Let's backtrack just a little bit. Is it accurate to say that one of the roles of the Tobacco Free Initiative is to oversee the implementation, or at least to maximize the implementation of the Framework Convention? Is that an accurate depiction of one of the roles of the Tobacco Free Initiative?
Exactly. We work with the, when a treaty comes into being, it sets up its own governing body, which are called Conference of Parties. They set up, and the Conference of Parties sets up a secretariat, which is housed in WHO, which is separate from the Tobacco Free Initiative. It's part of the Director General's office. And the Tobacco Free Initiative works with this convention secretariat and uses our comparative advantage, the fact that WHO has presence in over 130 countries of the world, mainly low and middle income countries. So we have country presence, we have on-the-ground presence to provide that technical assistance, communications, awareness building, partnership building that governments so much need, actually, to scale up their efforts, and also, as I said, to counteract the very ruthless and pervasive activities of the tobacco companies.
Yes. A treaty or a convention is as good as the commitment that the nations who create it bring to the table. Signing the treaty is the first level of commitment. Ratifying a treaty is a more advanced form of accreditation. As far as this convention goes, where do we stand in the tally? How many nations have signed on? How many nations have actually ratified the convention?
So I think it's probably most relevant to refer to the total number of countries that are full parties now. So it's 173 state parties plus the European Union that are full parties to the treaty.
These are nations who have internally approved the treaty or ratified it internally.
Yes. And these are countries, a treaty legally binds the entire country, a commitment to take specific actions. And as far as framework conventions are concerned, these are a type of international law that typically with the environmental treaties were more general at first, and then they generate protocols that are more specific. But in fact, the Framework Convention is quite unique, in fact, that it has very, very specific provisions, and in this sense, time-limited provisions on things like advertising bans and pack warnings, the type of pictorial warnings that are now being implemented as a best practice, and in America, in the USA, are encouraged in the treaty. So it's a very revolutionary treaty, and it was WHO's first, and also it was revolutionary in the sense that health ministries had never had the role of leading a governmental process to ratify a treaty, to bring the cabinets together and write the documents for the parliaments, etc., and move forward this domestic action to ratify a treaty. And when the negotiation was finished, there was some concern. Maybe this is going to take some time before we get because there's always this magic number, what is called entry into force of a treaty. So when a treaty is adopted and it becomes final text, it's not necessarily binding on countries. You need a number of countries or whatever, a formula for it to enter into force. Mm-hmm. And this one was 40. You had to have 40 countries that had become full parties before this process of entering into force and becoming a binding treaty took place. And miraculously, and this shows the power of the process. I mean, the civil society action, the commitment of the countries, etc. This one, according to the treaty section of the UN, entered into force faster than probably any other UN treaty, modern treaty in UN history since the creation of the United Nations in the 1940s.
Has the United States been a party to the treaty, or has it signed it? Where do we stand on that?
The United States is a signatory to the
Mm-hmm.
treaty. So there are, and don't want to go into that too deeply. There's 168 signatories to the treaty, but signature to a treaty is a kind of time-limited thing. It's a kind of, it's a bit of a pressure cooker approach in international law that you get 12 months from the time that the treaty is adopted to try to encourage countries to sign up and make a commitment that they'll move towards becoming a party to the treaty. So after that, in this case, 1 year in 2004 was finished, there can't be any more signatories. So there's going to be forever and ever 168 signatories to the treaty. The parties will continue to build because there are other methods that a country that didn't sign can still become a party. So the treaty in that period between 2003 and 2004, the U.S. government signed. So what signing a treaty does is it indicates that you won't undermine the general objectives of the treaty, and you have one right as well to you receive notifications about the status of the treaty. We understand that the process in the U.S. is as far as looking at the treaty and the compliance of the U.S. with the treaty provisions is very good. That basically all of the measures
right.
in the treaty are.
So whether it's ratified or not, you're generally satisfied with the stance of the U.S. as a global citizen in this arena.
U.S. has been very supportive. One of the major U.S. donors and the U.S. government and agencies like CDC are some of the biggest supporters of global tobacco control. It would be great to have the United States as a party to this treaty, and I personally am very optimistic that will happen. But every country has different processes that they have to go through, and sometimes those processes are more politically straightforward. In other cases, they're more politically complex. And every country has its own way of doing it, actually. And there's no time limit for that to happen. So very optimistic then, and hope that the U.S. will ratify in the not-too-distant future.
Going back now to the high-level meeting, how did tobacco control figure into the deliberations?
Right. The focus of NCDs and the global approach to non-communicable diseases has been evolving for about 11 years. A historic moment was 11 years ago when our World Health Assembly, this is kind of like the Global Health Parliament that meets in Geneva every May of our 193 member states, and they adopted a global strategy on NCD prevention and control. This was followed by several steps. 2003, the adoption of the Framework Convention on Tobacco Control, another milestone. 2004, a non-binding strategy on diet and physical activity, physical inactivity. 2008 was then the gestation and the formalization of the global strategy on NCDs as an action plan to kickstart and push countries' capacity and augment countries' capacity to deal with the four main non-communicable diseases that represent the major burden of disease and deaths due to non-communicable diseases. The bulk of the 36 million non-communicable diseases per year. Those are cancer, heart disease, cardiovascular disease, stroke and heart attack, chronic respiratory diseases, and also diabetes. And then those four, combined with the other four, we call them the 4x4, the main modifiable risk factors, which are the major entry point into primary prevention, are, as the primary behavioral risk factor is tobacco use and diets and unhealthy diets and physical inactivity, and alcohol use are the major modifiable risk factors. So those were set as priorities. The 4x4 is a concrete way of addressing the non-communicable disease burden, especially in low and middle income countries where health systems and prevention strategies are very weak, and where, in fact, in low and middle income countries in the developing world, globalization as well too, about healthy diets, the tobacco industry penetrating the markets, etc., have led to increasingly menacing and problematic escalation in NCDs. So the framework then moved forward. In 2010, there was an adoption in our World Health Assembly again of an alcohol strategy. Going into the Non-Communicable Disease Summit heads of state meeting here, where there were over 30 heads of state participating, tobacco is one of the major modifiable risk factors. And here, I mean, tobacco is very unique because it's the only one with a treaty, a binding international law, which is almost universal. Almost 90% of the world's member states have ratified the treaty. And we've now had several years of experience through, for example, our collaboration through the Bloomberg Initiative to reduce tobacco use and the Gates work in Africa to show that actually there are cost-effective measures at the heart of the Framework Convention that are proven to make a difference as far as tobacco use.
And have those been, to your satisfaction, incorporated into both the deliberations and eventually into the political declaration?
Exactly, yes. I mean, tobacco, I sat in the plenary, for example, yesterday, the plenary when there's over 100 interventions, so the plenary when heads of state and ministers were making their declarations and statements in the General Assembly plenary, and tobacco certainly was seen to be one of the top priorities, the most doable, that the measures lead to a ready impact and measurable impact, and a great support of the member states here in the UN General Assembly to move towards the full implementation of the WHO Framework Convention on Tobacco Control. And we know that this is doable, it's workable. We have best practices like Turkey and Uruguay, for example, that have really scaled up their tobacco control programs in a relatively short period of time. I mean, Uruguay has now some of the toughest tobacco control laws and enforced measures, regulatory environment in the world. And almost complete bans on advertising. They were the first country in this hemisphere to ban smoking in all public places, workplaces, like the ban on smoking that you have in New York City here. They offer cessation support, counseling, and support to population in the healthcare system. They have the biggest pictorial warnings in the world and high taxes to assure that tobacco is less affordable. And countries like Uruguay were able to demonstrate a 25% reduction. This is phenomenal, of tobacco prevalence use, adult use between 2006 and 2009. So this is just proof that tobacco control measures are affordable and they're effective. And
just before we leave the high-level meeting, were there elements of the discussion, and particularly the political declaration, which is the deliverable of such meeting,
right,
that fell short in terms of your expectations specifically on the tobacco front? for example, advertising bans and other means that you have mentioned, has all of that more or less lived up to your expectations?
Yes, the risk factor approach is incorporated, etc. And looking at the broader agenda, I mean, they're going into the negotiations of the political declaration of the high-level summit. There were issues, for example, the whole of government approach, the need to take into consideration the health impacts of different sectoral policies, for example, trade and finance, etc. Those were a subject of debate amongst the member states in August, but they've now been recognized in a whole chapter of the treaty. Also, something that was a matter of much debate was the issue of setting targets. I mean, while the Millennium Development Goals were so successful when they're adopted, they've set targets that countries are accountable for following up actually on. And so there was a great push to have targets for the NCD reduction and also the reduction of exposure to risk factors. And a very good output of the declaration is that while the detailed targets aren't included in the political declaration, there's now a mapping out process that WHO will work through its expert networks and also with its member states to advance the work that's already being done on targets, to then present targets to our governing bodies, etc., then come back to the General Assembly. And those are again going back to the previous theme of what gets measured gets done, or hopefully gets done. You've got to have those surveillance systems and those targets in place to hold countries accountable. And also issues like the links between the non-communicable diseases and the Millennium Development Goals and development are recognized in the declaration now. Those were issues that were a bit sensitive during the negotiation, but are there. Also, recognition of use of flexibilities of what are known as the trade-related intellectual property agreements of the WTO for access to essential medicines. There's references now to those flexibilities in the declaration. There's big challenges ahead. I mean, this Heads of State Summit is a huge milestone. I mean, just exciting, an honor to be here. But now there's a roadmap of where to go from here. It's raised the awareness at the highest levels of government. And so it is a new beginning again at a much higher level.
So you would give the meeting, the high-level meeting, a very fine grade for its overall performance and for where it puts the non-communicable diseases on the road to hopefully successful resolution in due course.
Absolutely. And I think the world community has come to the conclusion that they can't avoid the fact that NCDs account for over 60% of deaths, that 9 million of those 36 million deaths are premature deaths, and 90% of those are in low and middle income countries. There's this misperception that this is a high income country problem, which is not the case.
Diseases of affluence, shall we say,
yes,
or lifestyle diseases.
Not at all. These are the highest exposure to risk factors: tobacco use, alcohol use, the marketing, etc., pushing the use of these harmful products are now in low and middle income countries, and the most vulnerable are the poorest populations in low and middle income countries. And they have the least access for treatment when they do have a heart attack or they get a cancer. The health systems are set up just not always even adequately to deal with all communicable diseases and maternal child health issues. That's what the MDGs focus on. But certainly when we get to NCDs, that poor families in low and middle income countries can have catastrophic effects from at the microeconomic level when they're exposed, when their breadwinner dies or gets sick from a non-communicable disease. First, they can't afford the treatment. You lead to catastrophic health spending, which can destroy a family's whole financing, and then the breadwinner dies. There's no longer a source of financing for the family. And what is really pushing this, and this is interesting because you might hear some saying, well, we really can't afford this in the financial crisis. But in fact, what's come out of this whole consultation process is that and I was quoted in a Chinese newspaper, that there really is no alternative in the times of financial crisis, because the costs of non-communicable diseases to the world's economy are huge. It's estimated that an increase of 10% in non-communicable diseases in a country reduces gross domestic product by 0.5%. It's the World Economic Forum, and 2 years running, has indicated that NCDs are one of the largest threats to global financial stability, and that's because they reduce productivity. They are having a devastating effect on health systems in low and middle income countries that are ill-equipped to deal with them. So in a time with lagging economies and needing to kickstart the world's economy, in fact, investing in non-communicable disease prevention control is an investment in our future. It's an investment in our future well-being health-wise, but also it's an investment into the economic well-being of the world.
Well, thank you for shedding such wonderful light on NCDs in general.
Yes.
But tobacco control in particular. And if we may close on a personal note, here you are, Canadian by birth, living in Geneva.
Yes.
Somewhere in between, we know you spent some time in Ethiopia and in Jamaica.
Yes.
Can you draw the thread, if you will, through all of those points in time and perhaps clarify what drew you into this arena and where you would like to go with that?
Okay. As an aside, I have a friend that says my body is equally distributed throughout the world after this last 20 or 30 years of leaving medical school in Canada, etc. But I think the thread through my career, whether it was work in a small primary practice in Jamaica or working in a famine camp as a volunteer medical doctor in 1984-85 in Ethiopia, and then working on a big refugee repatriation project to stabilize and provide development assistance and medical public health assistance to 500,000 refugees coming back from Somalia. The thread was the need to make a difference, and the challenge to make a difference that would improve the world. And this is what drove me on to, as a medical doctor, a rather different course in the sense that there aren't too many of us that have gone on and done a PhD in international relations and political economy at the London School of Economics, which I have done besides my Masters of Public Health in London. But it was an inquiry and a discovery side of my personality to put different puzzles together and solve problems, complex problems, which now are so relevant, actually, and the big issue of making a difference. Because when we're discussing at the high-level summit here, it's all about health and all policies, a whole-of-government approach, thinking how trade policies might intersect and cause adverse effects in public health. So for me, it's about having the big picture, being a problem solver, and dedication to public service, and wanting to be part of making a change for the betterment of current and future generations.
Thank you. On this note, sincere thanks to Dr. Bettcher and to you, our viewers, for joining Medscape One-on-One. Until next time, I am Adashi.